Good morning. Hi, I'm really happy to have everyone here. I am Dr. Susie Spitznaz, and I have been working on organizing this meeting for about 2 months on behalf of ONDCP. And the first speaker we are going to hear from today is our director, Mr. Gil Kurlikowski, who has been an inspiration to me since I've been with ONDCP since November. And come on up, sir.
Well, good morning, everybody. We certainly have the smartest people in the room on this. You don't have the smartest person at the podium, but you've got the smartest people in the room on this really complex issue. I want to make sure that I recognize two of our deputy directors are here, David Mineta, that many of you know, David, and our deputy director for our international relations, because this is an issue that really does span the globe, Marilyn Quaglati is here also. We have a number of representatives also from Congress, and we very much appreciate not only their interest, but most importantly, the interest of their bosses that have taken this issue on, and we're going to learn a lot. We're here to listen, and we're really glad that you're here. We're glad that you're here for a whole host of reasons. One important reason is that as you may know, when it comes to conferences, I think we can usually serve water out of a drinking fountain, but because we invited people from state and local government and the private sector, we could actually serve coffee, and so we couldn't be more thrilled about that first thing in the morning. I appreciate so much you all taking this very thoughtful approach to what I said is really a very complex issue. I've been watching this and listening to many of you in the room over the last several years on the prescription drug front, but more in particular in the last 7 or 8 months on this. Florida, Washington, Tennessee, Kentucky, a number of people who have talked to me and said, what we do best at ONDCP is to bring a diverse group of folks together and then try and help to set policy and direction and to make a difference. And frankly, on the prescription drug front, I think we are making a difference and are going to continue to do that. This is something that we can call a lot of attention to, but the solutions and what will improve the situation, really, they come from you. The issue is receiving a lot more public attention, whether it's on CNBC, whether it's on from Brian Williams, a number of other locales. And when the message comes from you all at the state and local level, I think it makes a huge difference. Substance-exposed infants put a new face on this prescription drug abuse problem. Over the past decade, we've really witnessed this alarming increases in substance abuse treatment admissions, emergency department admissions, and most disturbingly, the deaths that are attributable to prescription drug overdoses. And the data from 2010 show that approximately 7 million Americans abuse psychotherapeutic drugs, while nearly 6,600 started to abuse prescription drugs every day. It's 2.4 million people a year, and the largest share of which started with pain relievers. We're seeing more and more consequences of what the CDC has deemed this epidemic, including the critical issue that brings all of us here today. The administration's National Drug Control Strategy takes a science-based, balanced, and a comprehensive approach to our nation's drug problems. And it reflects how much we have learned about how to prevent as well as how to effectively treat substance use disorders. And as a former police chief and a longtime person in law enforcement, I can be a bit of an unexpected messenger, both nationally and internationally, on this when we talk about our drug problems from a public health perspective, from a Department of Education or an educational perspective, from a grassroots perspective, really talking about prevention and treatment, really less so than just the criminal justice system. And we know that the criminal justice system will continue to play an important role in this. Well, we know much more about the chronic nature of the disease of addiction and how drugs affect the brain, particularly over the last few years. We know that most people who initiate drug use as teens They do so before their brains are mature, before they're fully capable of considering the risks and the potential long-term consequences of their action. And I often cite some of the research that is out there about making sure that if kids can stay away from alcohol and drugs up until the time they're 21, and you know this very well, the chances of them ever becoming involved or having a drug or alcohol problem are almost minimal. You know, I kind of made a mistake with an audience a couple of weeks ago in saying that. Several of them wanted to go home and just lock their teenagers up until they're 21 and then release them. So, but that's not what we're advocating, because we know that kids actually do listen to their parents. We know that addiction is a disease and it can be treated. We have to end this cycle of shame and stigma and guilt that prevents pregnant women from seeking treatment for the disease of addiction. And I know that we have to be very careful in the way we talk about this. Words have so much meaning, and several of you in the audience have pointed those words out to me, and so I try to be very cautious. And I go back to kind of my own getting out of the Army in 1972, and if you remember, there's a couple of you here old enough to remember those days. Getting out of the Army in 1972, there was a strong belief that we would have a wave of returning veterans that would be addicted to a highly potent form of heroin. In fact, that wasn't true. And if we look at other myths, we also thought that there was also a lot of discussion and a lot of public about a wave of children born to mothers who had done crack cocaine, that we would all have these horrible, significant problems. And neither of these things has proven to be true. And I think we're it's very important for us, and the last thing in the world that we would like to do is to paint this issue of the drug-exposed infants due to prescription drugs is then having so much more difficulties in the long run. We have to wait for the research. The crack cocaine epidemic taught us a lot of valuable lessons, including that need to speak carefully. And there's much that's still unknown about the extent and the consequences of neonatal abstinence syndrome. And I am particularly grateful to so many of you here, Dr. Patrick and others that have done the research. And the research is often read by lots of, like you, very smart people that are in the field. But we have this opportunity through not only forums like this, but a lot of other opportunities to get that message out to a much broader audience. And only by helping people understand the problems and the recognition can we make a big difference. We do know that there's an increased use of opiates among women of childbearing age. We don't have as much information as we would like regarding the prevalence or the long-term effects of prenatal exposure to opioids. And just like a lot of other areas when it comes to our drug problems in this country, there's a lot of gaps in the research. The research is not always as relevant. It certainly is not as timely. And it makes leading the policy discussion and leading the policy decisions difficult. So we have worked very hard with a number of federal components, but also at the state and local level to have better data systems. We need to understand also the scope of the issue through improved hospital and public health data, because that is the kind of information that will help us address this. And that's why all of you are here today. We're gathering the best minds, and I really mean that, the very best minds, examining the data, discussing the barriers, identifying the solutions, and helping to determine a coordinated response to this issue. It's no secret about our fiscal issues in this country, and when I first got the job and the president said, do you think we could make progress in this area? So over 3 years ago, not just this area in particular that we're all here for today, but this broad range of drug issues, I naively and optimistically said, of course, Mr. President, we can make progress in this area. And he looked at me a little quizzically, and I said, the wind is at our backs. This difficult economy then, and continuing difficult economy, has forced collaborations and cooperation and partnerships that I'm not so sure would happen or would exist if we all had our own pots of money and we all had our silos. And oftentimes when we talk about those silos, we know that we need to break those down. If you're inside the Beltway, you call them centers of excellence, but we won't. If you're outside the Beltway, you call these silos that really do need to be broken down. And that's why when we have people like Dr. Spitsnaz on loan to us, Jack Stein, who was on loan to us for quite a while and is now heading up a division at NIDA. We have these embeds at CDC and other places. We have this wonderful opportunity as a result of this to break down those silos and to put people together trying to figure out smart ways to address the problem. The challenge is getting help to women and their children and recognizing the challenges that a pregnant woman can face as she seeks treatment. We have to remember that the substance use disorders are quite treatable, and if I listened early on when it came to things like methamphetamine, I was told so clearly by so many people who actually didn't know that, well, you know, once you're addicted to methamphetamine, you can never recover, and that's pretty much it. Well, there are people here in this room that have treated and are involved in the treatment of people who have abused and been addicted to methamphetamine, and we've literally seen, and I have met hundreds of people, you know, that are back in their communities. They're back being productive. They're back taking care of their families. Those are all important things, and sometimes those messages just don't come out as forcefully as they should. Family-based treatment centers can provide women struggling with addiction with substance abuse treatment in safe environments and without separating them from their children. And it shouldn't have come as any surprise to anyone anywhere that when a woman says, I need help with a drug problem, they say, well, we're happy to help you, but we'll have to find, or you'll have to find someone to take care of your children, that she said, gee, I think I'm going to forego the drug treatment program. So we are strong advocates and push in a variety of ways for family-based treatment. And we want to provide the supportive services to assist mothers on their paths to drug-free and independent lives. Family-based treatment programs offer supportive services for children, and that includes health care. And of course, they also provide, as I've seen so often in these all too few family-based treatment centers, they provide the kind of nurturing psychological and supportive care to those children, because the drug problem isn't just the problem of the parent. It can provide a supportive, stable environment in which the mother and the baby can continue to receive care without the risks of returning to unsuitable, unstable, or unsafe homes. Additionally, many of these programs offer prenatal support and care with women with addictions that they would not access normally. Well, this is really an historic moment, and you are truly in an historic building. And in fact, I think this is the first time in 6 years that there has not been scaffolding all over this building. And to see where we are here in the Indian Treaty Room, I think helps to put a level of the historical significance of really what this meeting is and what it can be. We should identify and support models that meet the needs of mothers and babies. We need to offering simultaneous treatment and recovery and support and allowing them to heal together. We support the expansion of these programs and the important pathway to addressing prescription drug dependence among parents and effects on children. As many of you know, we've taken strong steps over the last several years to address the broader prescription drug abuse epidemic as well. One that I was totally unaware of, and you think as a police chief who takes a sworn oath of office to protect the people that he or she is responsible for, you really pay a lot of attention to what hurts them. And frankly, during my confirmation hearing, I was really unaware of the problems of prescription drugs. But if I was unaware of it, I certainly went out and then tested all my friends and colleagues who were very much unaware of it. You in this room knew these issues very well, but we have a bit of a bully pulpit, and we have a bit of an opportunity to get that message out to others to better understand this. Over a year ago, we released the Prescription Drug Abuse Prevention Plan. Many of you had a voice in that plan, and you came to work with us for almost an entire year to develop the plan and the strategy. And it includes the 4 pillars of education for prescribers and the public, prescription drug monitoring, safe drug disposal, and effective enforcement to address rogue prescribers, pill mills, pain clinics. And we know that there has been progress, significant progress in every one of those areas. With the cooperation and partnership of national leaders like yourselves, the experts that you are, we're going to continue to make significant progress. And in closing, I want to thank all of you for your commitment to reducing and preventing prescription drug abuse, and particularly for the most vulnerable in your communities. I appreciate very much all of you being here and spending the time with us. Let me just also mention that we are very open to your ideas, your suggestions, your thoughts. I mean, this really is a foundation for what ONDCP is supposed to be and what we're supposed to do, which goes back to our founding back in 1988. We're supposed to bring lots of people together and figure out collaborative ways to deal with these problems, to reduce the problem, and also to bring it to the attention of other people who can do that. So I thank you for being here. I cannot thank Dr. Spitsnaz enough for not only her agency sharing her with us, but for the work that she has done in gathering all of you and putting people together. I would tell you that we could have easily had a couple hundred more people, but given the size of the room and the fact that we wanted a good exchange of dialogue and discussion, you're here and you're very special, and we know that this information is going to be not only through the webinar, but will be rebroadcast and used in a variety of ways. And we're going to make a big difference in this problem, and I think you're going to see that we've already made some progress overall on the prescription drug issues. So again, thank you so much for being here.
So I'm just going to go through a few housekeeping issues. And as the director mentioned, I am on loan from the National Institute on Drug Abuse, and there are a lot of my colleagues here from NIDA, as well as many grantees whose research we're going to hear about today who have been supported by NIDA. I've also been really privileged this year to have a number of amazing colleagues at ONDCP, and I have to thank a few people really fast. One is Ms. Hackett, who's over here in the corner, and Ms. Hardesty, who has helped us with the webcasting. This will be webcast, and we will, I believe, also have it archived so people can watch it later. And anybody who's tweeting about the meeting, we are using #neonatal to talk about the meeting on Twitter, and hopefully there'll be a lively conversation with respect to that. Since we are doing this, and also the meeting is a public meeting, and so it will be transcribed, it's very important for people to speak into the microphones, and both the speakers and anybody who wants to ask a question in the audience. We are going to have 3x5 cards, and Renee Hanna, who is in the back raising her hand, who is our new senior policy advisor, will be handing those out if we don't get to your question during the talks. The way this is going to work is there will be panels, and we're going to ask our panelists to come forward during the discussion period and sit at the table so that you can respond into the mics to any questions that you get. And we're also going to have time for approximately one question after each talk. Victoria Kaminsky, who is over here on this far corner, is going to be our timer, and she will be holding up an awesome iPad app that will let the speakers know what time they have. So when you get to 7 minutes, it's going to flash green. When you get to 9 minutes, it's going to flash yellow. When you get to 10 minutes, your time is up, and we really have to stay on time. I have this horrible sounding ringtone on my phone. It's the old car horn, and nobody wants to get the old car horn. So, do your best to try to wrap it up when you get to that time. The bathrooms are down the hall near the exit sign, the big main hall that cuts the building in half. Women's are on the right, men's are on the left. And we will be having a break after the first panel, and then a break for lunch, and then a break after the middle panel in the afternoon. So hopefully, and lunch is going to be available downstairs in the cafeteria. I apologize for the seating situation. We are going to do our utmost to get some more chairs into this room, probably during the break. So I think that is all of my issues. In terms of introductions, there are bios in your packets about the speakers, and we also will be able to send those out if people did not receive packets after the meeting. We're going to send, a big thank you and informative email around when we're finished, probably Monday, Tuesday. So that will be an opportunity, hopefully, for everybody to continue interacting from this meeting. And it'll have updated speaker information, et cetera. So when the moderators do each of their introductions, we're going to introduce the speakers at the very beginning and have just short little introductions. So hopefully we can stay on time. So without further ado, I'm going to go ahead and introduce the speakers in the first panel. The first panel is going to cover essentially the science of what is happening with opioid exposure, with neonatal abstinence syndrome, and some really recent information about cognitive outcomes. And then we're also going to hear from a person who has been working as a nurse for quite a bit of time. So our first speaker is going to be Andre Jones. Dr. Andre Jones from Research Triangle Institute, who is an internationally renowned researcher. She has done work in South Africa. She has done work in the Republic of Georgia, not to mention Baltimore, which is probably one of the hardest places to do this kind of work. Certainly a lot of need there. And then next we will be hearing from Dr. Stephen Patrick, whose paper in the Journal of the American Medical Association has really, for the first time, given us some estimates of what the situation is like nationally and what changes have occurred in the past since 2009. Then we will be hearing from Dr. Carol Kaltenbach, who's from Thomas Jefferson University, about the cognitive outcomes for these children. And she was an investigator on a very large, important multi-site study called the Mother Project, which Andre is also going to talk about a little bit later today, too. And then finally, we will hear from Cheryl Harrow, who is a nurse and is a doctoral student in nursing. And she will be talking about her experiences, and we're going to have a little multimedia presentation when we get to her. So Andre, come on up and kick it off. Speakers need to bring their handouts because you may not be able to see your slides. And there's a clicker, which is also a laser pointer. Do you have the handouts? Okay. Or they're in the big packet and they're in order. So. You can put your tent right there. No, it hasn't started yet. Ready, set, go.
All right. Thank you very much. It is a true honor and privilege to be here today to share with you some of the information, and I greatly thank ONDCP and CC Spetsnaz for the opportunity to be here. With the time that I have available, I am going to talk to kind of set the stage, in addition to the lovely stage that Mr. Kolakowski has already set for us, to talk about the historical as well as the current context of opioid use during pregnancy. This is not a new problem. It was identified at least in the 1880s in the United States, where we had physicians who were prescribing opioids to women, and that was the main way that they got their medication and started their opioid addiction issue. And then there was also reports of women who had babies that had opiate withdrawal, and very forward-thinking physicians were actually giving morphine to treat that opioid withdrawal because they found out if they did not treat it, babies would die. And unfortunately, with the 1914 Harrison Narcotic Act, it really had the consequence of marginalizing addiction treatment and taking it out of mainstream medicine. I think we've done a great job of getting it back into mainstream medicine, but our job is not done. And so there is work yet that I'm really glad we're all here to work on. As Mr. Kolakowski already told us, the crack baby epidemic was something that was important in the media. It got a lot of attention. It created the most stigmatizing time for women and for their children, and it cast these women as unloving and very selfish mothers. There was a lot of legal actions that I know Lynn Paltrow will talk about against these women, and we don't want history to repeat itself. We want to take a new approach with the rise in opioid use disorders that are occurring now and avoid having a situation where it's taken research 20 to almost 30 years to be able to correct the misinformation about prenatal exposure to cocaine. I also want to tell you that when we look at this topic, I think it's important to put it in a life perspective. Women are using drugs before they get pregnant. They often come to our attention when they are pregnant, but it is part of a life course. And to keep that in mind throughout the day as we talk about this. And so postpartum treatment is just as important as prenatal care. Also, and I know Steve Higgins is going to talk about this later today, the most common drugs that are used during pregnancy are our traditionally illicit drugs, our tobacco and our alcohol. And so we don't want to forget those when we're talking about this topic, because most of the pregnant women that I've worked with are comorbid drug users. So they're using alcohol. 95% of them are smoking tobacco. Nope, doesn't want to move forward. There we go. And to define the topic of our day, it's neonatal abstinence syndrome. And in the slide that I just showed you before, you noticed that the alcohol and the tobacco were the two larger bars, while the illicit drugs are the very smaller bars. We know that fewer women, while they're pregnant, are using drugs, because once they become pregnant, some women are able to stop, others need our help. And those women, the women that are using the illicit drugs, are the ones that are getting the most scrutiny from our society, and they need our support for the mother and child dyad, not to pit mother against child. And so with the opioids, there is a neonatal abstinence syndrome. Carol will talk more about that, as will Cheryl Harrow. And to define it for us, it is a neurological excitability. So the babies can be irritable, they are crying, they have gastrointestinal dysfunction, so they have uncoordinated sucking and swallowing. So it takes a lot of nursing, mom care, and physician care to help these babies be treated, but they can be treated. We have excellent tools to assess neonatal abstinence syndrome, and we have great treatments. And we also know that having a neonatal abstinence syndrome or recovering from a neonatal abstinence syndrome does not doom you to a poor life. What is most important is the postnatal environment in which these children grow up in. Dr. Patrick is going to talk about his data, and so I will not steal his thunder, but other just to say that these data have been terrific for giving us a stage and a forum to really talk about this issue. We know that opioid use during pregnancy is rising, and I'm really glad that we are here today to talk about solutions. It has also gotten attention from policy and opinion-setting bodies, the neonatal drug withdrawal from the American Academy of Pediatrics, that's been updated recently, and there's been a joint committee opinion by ACOG and ASAM, which is really helpful in providing guidance for how to move forward on this issue. Obviously, there's been a tremendous amount of media attention, and Senator Schumer in July has called on the FDA to look at labeling. He's also called on SAMHSA, as well as NIH with NIDA and the CDC to help, let's get the research going to prevent addiction and to treat the addiction. And I know that CDC has responded. There's a meeting in 2 weeks about this issue. NIDA has a lot of grants in the pipeline, at least I've heard from my colleagues, and the CDC, this Clinical Trials Network would be a fantastic forum. They've got the right population, the right centers. They could easily implement prevention protocols, treatment protocols, and we could get solutions. That's a well-oiled machine to be able to do that. I also don't want us to forget about the context of this issue. The crux of it is, why are more women using opioids before pregnancy and during pregnancy and after pregnancy? And there is a rise in pain clinics. I mean, Florida is an important example of where pain clinics were increasing. I know that the brothers that were behind that are now incarcerated, but I don't want us to forget about our policies. What, from a structural level, can we do to reduce the access to these illicit, or to these prescription opioids? This is my most important slide. If you remember nothing else, I want you to remember this one, because drug abuse does not occur in a vacuum. It occurs in a rich, contextualized life of a woman. And the women, at least the ones that I've seen at the Center for Addiction and Pregnancy and in many places around the world, they have all of these issues going against them, but they also have a tremendous number of protective factors. And these are all the issues with or without drug abuse that can impact mother and child outcomes. And so we really need to focus on poverty, on access to education, on access to treatment, on access to treatment for psychiatric disorders, on food insecurity. Many of the children that we see that are hyperactive in the Center for Addiction and Pregnancy, they've come in and they're hungry. If you give them food, that decreases their hyperactivity. So there are structural things that we need to think about that we can do. We're going to talk about these in the afternoon in terms of successful prevention for opioid addiction and pregnant women. We need a multi-level approach, and I think that there are a lot of ideas in this audience and through the discussion that will come out about how we can move forward with that. We need to focus on how to best alleviate those factors, those structural factors, the individual factors that lead to initiating drug use and maintaining drug use. And I have to say, to give some examples of patients that I've had the privilege of working with, there are women that have worked on Wall Street that got a 30-day supply of Vicodin for tooth pain that ended up becoming addicted and becoming pregnant. And they were scared to go to the hospital because they knew if they walked in and and they told the physician that they were on buprenorphine or methadone, that their baby was going to have to be treated for neonatal abstinence syndrome. So they didn't want to go to the hospital. They wanted to have home birth. There are women that came to the Center for Addiction and Pregnancy that started using opiates at 10. The reason they started using opiates at 10 was because they were injected by a sexual abuser who was giving them opiates to shut them up so they could abuse them. So women come from all walks of life. They have a tremendous amount of different things that have happened in their life. But it's not to look at them as victims. It's to look at them as survivors and what we can do to enhance those structural characteristics, the individual characteristics, to build on their strengths and minimize their weaknesses. And finally, medication has a role in stabilizing opioid-dependent women and preventing relapse. In the afternoon, I'll share some of our data from the MOTHER study that was published in the New England Journal of Medicine, comparing methadone and buprenorphine. The outcome is that we have two great medications when used appropriately and given in appropriate doses to treat opioid-dependent women. So in summary, we know that alcohol and tobacco are the most commonly used drugs. We know that some women are able to stop while others need help. We also know that the opioid addiction problem is a growing problem, and it does have public health consequences. We know that the increase is being seen not only in pregnant women using drugs, but in increases in neonatal abstinence syndrome also. And we know that this is a complex issue, and a complex issue deserves a multifaceted, multimodal treatment, intervention, and prevention to really address and solve this issue. And I haven't gotten the car horn. And those are my children. Thank you.
Thank you. Thank you, Andre. Go ahead and come on up, Dr. Patrick. And why don't you sit? And if somebody would like to borrow Andre's chair for a moment, that would be fine too. This is the laser pointer, in case you want to point. This is the clicker.
Well, good morning. I'll wait for the slides to light up, to come on up. It's quite an honor to be here this morning. I was asked to talk about our recent study on neonatal abstinence syndrome, and it's entitled Neonatal Abstinence Syndrome and Associated Healthcare Expenditures in the United States from 2000 to 2009. Again, I'll wait for the slides to load up. I could, yeah. I'll start talking a little bit while they're loading up. Well, prior to our study, there were data to suggest there was an increasing trend in neonatal abstinence syndrome. As an example, the Florida Medicaid program had recently described a 5-fold increase in the diagnosis across their state. In addition to documented trends in communities like Florida, we knew that data from the Centers for Disease Control and Prevention had suggested that opiates, there we are, that use of opiates, which is the main cause of drug withdrawal in neonates, was on the rise in the general population. This is a little bit hard to see on this screen, but these are trends from the Centers for Disease Control and Prevention. Opiate pain reliever prescriptions are in the dotted blue line. Opiate pain reliever overdose deaths are on the solid line, and opiate pain reliever treatment facility admissions are in the broken blue line. On the y-axis is rate, and on the x-axis is year. From this, you can take away that prescriptions, abuse treatment admissions, and deaths due to opiate pain relievers have increased substantially over the last decade. Oops. Nice. Even with these documented trends, there were no national estimates on neonatal abstinence syndrome. Given this, our study objectives were to provide national estimates on NAS and its complications, maternal opiate use at the time of birth, and healthcare utilization related to NAS. For our study, we utilized hospital billing data from around the country, sampled to achieve national representative estimates from 2000 into 2009. These data were obtained from the Federal Agency for Healthcare Research and Quality. Specifically, we utilized the Kids Inpatient Database for newborns and the nationwide inpatient sample for mothers. These data are compiled from 44 states, and they include thousands of hospitals and millions of patients. Newborns with NAS were identified using the diagnosis code for drug withdrawal syndrome in a newborn. Presumed drug withdrawal from medical treatment, for example, a newborn receiving opiates after a painful surgery, were excluded from our analysis. Sorry, it's advancing on me. Mothers were identified if they had delivery during their hospitalization and had diagnostic codes associated with opiate use or abuse. In addition, we evaluated common newborn complications and diagnoses associated with neonatal abstinence syndrome, including feeding difficulties, being born low birth weight, respiratory diagnoses, and seizures. Our results. This table represents characteristics of newborns with neonatal abstinence syndrome in 2009 compared to all other hospital births. In the left-hand column, you'll see babies with neonatal abstinence syndrome. In the right, all other hospital births. In 2009, of nearly 4 million births in the United States hospitals, there were just over 13,500 newborns diagnosed with neonatal abstinence syndrome. These newborns were more likely to have respiratory or breathing problems, more likely to be born low birth weights, much more likely to have feeding difficulty, which often prolongs their hospitalization, and more likely to have seizures. And nearly 80% of newborns with NAS were covered by Medicaid, compared to less than 50% of all other hospital births. In this figure, we're looking at a time trend in the incidence of neonatal abstinence syndrome from 2000 to 2009, and this was derived from our analysis. In the y-axis, we have rate of NAS per 1,000 hospital births, and in the x-axis is year. From 2000 to 2009, the rate of neonatal abstinence syndrome increased nearly threefold, from 1.2 to 3.4 per 1,000 hospital births. Okay. In this figure, we have the time trend of maternal opiate use and abuse. On the y-axis is maternal opiate use and abuse per 1,000 hospital births, and on the x-axis is year. From 2000 until 2009, maternal opiate use or abuse at the time of delivery increased nearly fivefold, from 1.2 to 5.6 per 1,000 hospital births. In this table, we examine time trends in the mean length of hospital stay and hospital charges for neonatal abstinence syndrome from 2000 to 2009. As you can see, over the last decade, mean length of hospital stay was around 16 days. It didn't change. And this is compared to all other hospital births, which averaged around 3 days. In contrast, mean inflation-adjusted hospital charges for NAS increased steadily over the last decade, to a mean of just over $53,000 per infant by 2009. Charges for all other hospital stays grew at a similar rate, but remain less than 20% of those for NAS. In this table, we have our estimates of national hospital charges for NAS over time and by insurance type. As you can see in the bottom row, total inflation-adjusted national charges for NAS have increased substantially over the last decade, reaching $720 million by 2009. As you can see on the top row of data, Medicaid is by far the predominant payer for these children, with aggregate charges of an estimated $560 million in 2009, compared to private insurers at $130 million. Our study does have some notable limitations. When using hospital billing data, both under and overcoding can occur, and one recent study suggested that billing data systematically undercodes NAS. In addition, it's possible that increasing clinician awareness of the syndrome might have accounted for some of the increase, rather than an actual increase. However, recent trends described in the general population by the Centers for Disease Control and our increasing trends observed of maternal opiate use at the time of delivery make this less likely. Next, it's important to know that not all charges that we gathered are all from neonatal abstinence syndrome. Some of them are from, sorry, my slides are advancing without me. Some of them are from routine newborn care. And then lastly, hospital charges are the hospital bill, and they don't equate directly with costs. In summary, the incidence of neonatal abstinence syndrome grew by threefold during our study period. By 2009, this equated to 1 baby born per hour in the United States with neonatal abstinence syndrome. And maternal opiate use and abuse grew by 5-fold. Hospital charges nearly quadrupled, even when adjusting for inflation. It goes again. Further innovation and standardization surrounding NAS is needed. This includes research and development that will improve identification and treatment of mothers and drug dependence of newborns with NAS. In addition, we know some best practices from existing research. There's evidence to suggest, however, wide variation in treatment of newborns with NAS, and a standard approach based upon existing knowledge is needed. Our studies also highlight some challenges to states. We found that 4 out of 5 newborns with NAS were enrolled in state Medicaid programs, and Medicaid now accounts for a substantial portion of state budgets. But this also highlights some important opportunities for states through modified regulation of opiates via prescribers, pharmacists, patients, as well as evidence-based practice incentives through Medicaid, including through managed care plans. I won't spend too much time on this slide because it's already been addressed, but there has been some recent attention from, at the federal level from several senators, including the remarks by Senator Schumer, which were highlighted earlier, as well as Senators Casey and Alexander, who wrote to the administrator of the Centers for Medicare and Medicaid Services to reach out to state Medicaid programs to help formulate a plan to stop NAS. In conclusion, NAS is increasing exponentially. Infants with NAS have longer, more complicated initial hospitalizations, and Medicaid bears a large burden for payment. But some key questions remain, including how best to prevent opiate use and abuse prior to pregnancy, there it goes again, advancing without me, and how best to standardize approaches to identify and treat neonatal abstinence syndrome. I'd like to thank the Robert Wood Johnson Foundation Clinical Scholars Program for their support of this work, the University of Michigan and my Division of Neonatal Perinatal Medicine, as well as my co-authors, Bob Schumacher, Brian Bennyworth, Liz Crayons, sorry, it's advancing again, Jen McAllister, and of course Matt Davis, my main mentor. Happy to take questions if there's time.
So I forgot to let Andre have her question. And so if, while they're changing the slides up, if anybody has a question for Dr. Jones or Dr. Patrick, there's a microphone over there, or if you're closer to here, you may come up to here and ask the question. If anybody has a question. No questions. All right. We will go ahead and have Dr. Kaltenbach come up. Use this to advance the slide.
Which one? This one here?
Yeah.
Okay. Okay. Good morning. I too echo my previous colleagues' previous statements that it's a tremendous honor to be here today and to be a part of this, what we consider a most important discussion. As you see from your program, the title of this panel is NAS, the Problem and Consequences. So my presentation this morning will attempt to delineate the different contexts of NAS and how they are important in defining the problem and understanding the consequences. So it's, my talk is divided into two main components, talking about the context of NAS and then talking about infant and child development, because obviously if we're going to be looking at development, we need to understand the context of the NAS and how it occurs. As Andre mentioned, this is not a new phenomenon. There certainly has been a lot of recent attention in the press to NAS, but this was first described in the 1950s as narcotic abstinence syndrome. That's where we get the name, an acronym NAS, even though it's now referred to as neonatal abstinence syndrome. And we tend to still think of it as specific to opioid exposure. More importantly, we tend to think of it in a very simplistic and unidirectional model. We're looking at, okay, there's opioids involved, that equals NAS, and that equals consequences. And I hope that for my presentation, you'll come to understand that it's not quite that simple, that it's very complicated, and that there are a number of factors that must be taken into consideration in our understanding of NAS. One of the first factors is the opioids themselves, because NAS, the presentation and severity of NAS does differ as related to what opioids the infant is exposed to. Certainly, heroin has a much less severe NAS than methadone. Its onset is much quicker. Methadone and buprenorphine have approximately the same onset, although buprenorphine is sometimes seen about 24 hours later. But as you'll see from the data that Andre presents this afternoon, NAS associated with buprenorphine is much less than NAS associated with methadone. Relevant to our discussion today, we don't have any data on oxycodone and hydrocodone, the prescription drugs that are most often abused. And we have a little bit of data on morphine from one study in Europe where they use morphine to treat opioid dependence in pregnant women. And we see that the onset is around 34 hours. They do have some data also on the severity, but since we only have one study and it's very small, I really am not comfortable in talking about those data. In addition to the specific opioids involved, though, we also have a number of other factors that people often don't take into account that affect NAS. Other drug exposures. Cocaine affects the presentation and severity of opioid NAS. Alcohol and nicotine exacerbate the presentation of NAS. SSRIs and benzodiazepines also have a significant impact on the presentation of NAS. We are just beginning to obtain some data that there's a genetic component. We also have data that their maternal physiology may be involved in the presentation of NAS, and we certainly know that gestational age is a factor, that you have much less NAS, much fewer infants who are born premature that require treatment for NAS. This becomes very important when we start talking about the difference between illicit use and licit use. We also know that treatment, the kinds of treatment we provide, are impacted by NAS. The assessment protocol that's used. Right now we have a standard protocol that's used by most hospitals in the country, a scoring method that was developed by Loretta Finnegan many, many years ago, but that instrument was developed in 1975, and any hospital you go to will say they use a modified scoring method, but we have no data on how those are modified and what they are. What we'll also talk about, we have a modified Finnegan that we used in the mother study that we do have some data on that may provide us with a more updated scoring tool. We also need to talk about the medications that are used for treatment. We know that most hospitals use morphine, which is very effective. We know that it's the most effective, at least we have some data that it's the most effective treatment. We have new research on buprenorphine that it is also a very effective medication for the treatment of NAS. We have a lot of hospitals that are using methadone. We have no data on the effectiveness of methadone and NAS, and we also know that the use of the medication affects the weaning protocols that are used by hospitals. Some hospitals are sending babies home before they're weaned from the medication. They're sending them home on methadone to, quote, grow out of the medication rather than weaning them, and so sometimes these infants are kept on this medication for 2 to 3 months. So there's tremendous variability. We also know that breastfeeding is an important factor. Although very little of the opioid it passes into the breast milk, the act of breastfeeding itself is a very nurturing interaction that alleviates a lot of the symptoms of NAS. So we know that breastfeeding is extremely important. We also are just learning that the treatment environment is important. A number of us who are based in hospitals know that when the infant has to go to the NICU, that is an important factor, that exacerbates the presentation and the treatment of NAS. And we now have some data that shows that when infants are cared for by their mothers and rooming in rather than treated in the NICU, that the length of NAS is significantly reduced. So we have to look at all of these factors. We also need to look at the difference between illicit exposure and licit exposure. When we're talking about illicit opioid use, we're certainly talking about heroin, but we're also talking about prescription misuse, which may include, of course, the pain medications that we focused on, oxycodone and hydrocodone, but it also refers to methadone and buprenorphine when they're used outside of an appropriate treatment modality. When we're talking about appropriate opioid use, we're talking about the use of methadone and buprenorphine for the treatment of opioid-dependent pregnant women, and we're talking about the appropriate use of pain medications for pain management when necessary. These have important outcomes. illicit use results in trauma to the fetus. If you have a mother who's using drugs, who's getting high every day, you're repeatedly subjecting the fetus to the trauma of withdrawal, and so you're increasing the chances for morbidity and mortality. Additionally, the mother may receive little to no prenatal care and have very complicated medical and obstetrical complications, and you have the increased risk of prematurity. When you're using the drug illicitly for treatment, we know that it prevents the erratic maternal opioid levels and protects the fetus from repeated episodes of withdrawal. And this is extremely important when we're talking about outcomes. We also know that when you're using the drugs for treatment, you have associated with improved obstetrical care, increased fetal growth, and reduced fetal and neonatal mortality. And additionally, medication supports and sustains maternal recovery so that she's able to care appropriately for her infant. So when we have NAS, when we're talking about the developmental consequences, we know that it's an easily identifiable and treatable condition. It has not been found to be related to adverse developmental consequences. Usually when you're looking at developmental outcome, you're not looking at it as a function of whether the infant has been treated for NAS or not. There's only one study that has looked at this, that took a cohort of infants that received treatment from the same facility and looked at the developmental outcomes at 6 months of age between the infants who had NAS that was severe enough to require treatment and the infants who had mild NAS. And in terms of their development at 6 months of age, there were no differences, and these infants were functioning well within the normal range of development. Oops, what happened? I can't get up. Can you advance these up to the end so I can keep talking rather than having a go? I will talk about the relationship, and when I say on these slides, the relationship between NAS and child development. NAS is a surrogate term for opioid exposure because I said we really don't have data that looks at whether the infants were treated for NAS or not, but certainly all of these infants exhibited NAS. We have long-term developmental outcome studies. We have about 30 years of studies. I need to go back a little bit. Okay, we'll get to this in a minute. We have about 30 years of developmental studies where we've looked at the outcome of infants who are exposed to methadone or methadone and heroin, and we know that their development is normal. We know, more importantly, that when you do find adverse effects, that they're a result of environmental factors and not a direct effect of the drug. We do not yet have data that addresses the short-acting prescription opioids such as oxycodone and hydrocodone. There are no data there. We have some new data that's just emerging on the effects of buprenorphine, and that's what I want to just quickly show you. It's from the mother study, which Andre will talk about this afternoon. We had 114 potential participants. Those are women that we had not lost to follow-up. 97 participants enrolled in the follow-up. It was a very comprehensive study. We had a battery of infant measures and maternal measures. But what I want to share with you today is, so that your take-home message is that these children do not have any long-term cognitive developmental problems. I'm presenting and you have in your slides, the Bailey data from 6 months, 12 months, 24 months, and 36 months. And the Bailey is the standard assessment that we use for infants in terms of assessing their cognitive ability. And what you need to look at in your handouts, because I know you can't see it very well on here, is on each side, look at the last 3 lines where it talks about cognitive, language, and motor scores. And you'll see that all of those scores are around 100, which is the average normal score for this instrument. So there's certainly no difference between the methadone-exposed and the buprenorphine-exposed children, but more importantly, these children are functioning well within the normal range of development on all items. We're currently finishing our analysis on all of the rest of the data, but I will tell you that it's going to show the same thing, that there are no differences and that these children are functioning very well. These are all mothers that were in treatment, And that's what we need to go back to and why we're talking about context. This is very different than mothers who are not in treatment, who are delivering babies without having good prenatal care and are not able to maintain and have support for their recovery. So the bottom line is that within the context of comprehensive treatment, the consequences of prenatal opioid exposure certainly can be ameliorated. We can have positive outcomes. These babies can do very well. And so when we're talking about solutions, again, we need to focus on the difference between illicit use and the use of these medications for treatment and how we can have positive outcomes and improve the lives of these women. So thank you very much.
Does anybody have a question for Dr. Kaltenbach? Okay, quiet group today. Let's have Ms. Cheryl Harrow come up and have our multimedia experience here. You're going to press this button when you're ready to play. Stop. And then you press it again, or you just hit that thing on top. Okay.
Hi, it's definitely an honor to be here. Carol and I have been working together ever since the onset of the mother study, so it's great to see her again as well. I'd like to give you a little audio visual of what things that we have dealt with. This is an NAS baby experiencing a diaper change. A simple diaper change can make these babies so upset. Now imagine this is your background in your office. This is where you're working. Imagine a couple other babies crying in the background. The nurses are busy. They don't have enough hands to hold all these babies. And so they're using assistive devices to make their babies feel like they're held. Your nerves are becoming a little frazzled now, and you're thinking, why isn't this mother taking her baby out to her room? Meanwhile, out in mom's room, she's sitting there feeling very guilty, beating herself up from the inside for what she's done to her baby. She's sitting there thinking, I don't even know how to care for my own baby. And so she doesn't take her baby out to the room. Video? Okay. I have a video, the other side of the coin, the baby who was not identified. And imagine you see a quiet baby laying over in its bassinet in the corner. It's wrapped up. And a quiet baby always makes me think, let's make sure it's okay. And I walk over, I open the blankets, and I see this. And I hold the hands across the chest to soothe them. So the baby self-soothes by sucking on its own lips and tongue. I let go of the hands. This is the child that gets missed. This is the child who was not identified early. Thankfully, these two are the worst case scenarios. Once we identify these kids, we do have good treatment programs. We have tools that we have proven are useful, and in research we know that these tools work to identify signs and symptoms. We can actually objectively look at the signs and symptoms, give them a score, and then treat them with morphine or other drugs. We teach the mothers the soothing techniques for their babies, and we actually allow the moms to room in with their babies, and so and even if they want to choose to breastfeed, we can assist them through that process as long as we don't have other illicit drugs and they're compliant with their treatment programs. We have regimens based on these NAS assessment tools that can tell us when a baby needs pharmacotherapy. And so based on scores, we can medicate the baby. We use morphine, which is a short-acting drug, and we can get them growing and feeding and sleeping, the things they need for normal development. During this time, we continue to educate the mother and the family. We also encourage them and give them the know-how to be able to feel confident when they get their baby home that they can care for their own child. What is important is the early identification. That leads to early prenatal care, and we know by research that this shows better outcomes for both the mother and for the baby. Standards of care. Every hospital has a standard of care. When you're admitted to labor and delivery to deliver, you get blood drawn, you get a urine specimen, you get all this testing done. Is it possible that we could add a urine toxicology to that standard of care? If I'm going to ask you, are you using any type of opiates? Have you used any illicit drugs? May we take a urine tox screen from you? What's the answer going to be? This problem goes through all socioeconomic statuses. This is just not limited to the impoverished. But ignoring the problem and no urine tox, let's pick which ones we think might be exposed. That's the wrong way to go about this. We have great community treatment programs. Do they routinely test for pregnancy? I actually did a phone survey because I wanted to know. Luckily, many of them do routinely do pregnancy testing before they start their women into the drug programs. But most of these women are in the age bracket for having children, and so we need to do this continuously. We have a lot of problems to overcome. Obviously, poverty. We still have a lot of lack of access to care. We need to standardize the Child Protective Services criteria. When are we going to remove these children from these women? And then we need to know what these women need to do to get their children back. We want to encourage breastfeeding because we know that this helps them through their withdrawal. There's not enough medication from methadone coming through. Hopefully, we'll be finding out about buprenorphine in the near future and how much comes through with breast milk. We've already submitted that one. So what can we do now? Right now, we need to start education in nursing schools, in medical schools. We need to have this in the general population. We need to consider what the outcomes are and how much money is spent on the population in healthcare dollars. By early identification, we can treat these women, get them committed, and have good outcomes for the babies. My recommendation, we need to develop a healthcare education curriculum. I'm not saying start in 4th grade and teach about when things are starting to happen into your body in puberty. I'm saying let's start way back in pre-K. Let's start with those 3- and 4-year-olds. We can teach them how to wash their hands properly, how to prevent themselves from getting sick. My own children, they participated in the Dare to Say No program, and I was even benefiting from that. I got to see what those drugs even looked like. Otherwise, I would never have had that opportunity. We need to take the curiosity out of these drugs and let the children know what the result is from taking these drugs. So if they know what it looks like, they know what to avoid. Don't let them get to the point where they're in a situation where they're getting peer pressure. Try this, it's fun. We need to get rid of that. We need to do the education from pre-K all the way through high school and college and throughout the entire population. One thing I do know, I spoke to Dr. Loretta Finnegan personally, and I said to her, what is the key to the use of your NAS tool? And she said to me, the NAS tool is not the answer. The answer is, regardless of what tool you're using, everybody using the tool needs to be able to use it the same way. In this situation, we can treat based on scores. We can avoid the higher weight-based dosing and get these babies out of the hospital and into their homes much more quickly and save healthcare dollars. Thank you.
Does anybody have a question specifically for Ms. Harrow? And our microphone is over here in the corner. If anybody wants to come up and ask questions of the panel, we can have folks line up. And questions, anybody? Raise your hand. Come see us if you can over here. I will ask a question of the first three panelists to take the moderator's prerogative and say, if there's something critical, a critical research question that you think the next step would be as far as developing a research agenda related to this issue, just in order, starting with Dr. Kaltenbach.
Well, I would have two. We do know that morphine is effective in treating NAS. We don't know that methadone is effective. We don't have any good research on that, and yet a significant number of hospitals are using methadone to treat these babies, and I think that it's critical that we have research on that. I also think that we need to look at dosing regimens and have some research on dosing regimens. Because every hospital is different. Every hospital's policy in terms of assessment and how they treat and how they dose varies. And at this point in time, we have a number of protocols that are out there, a number of treatment guidelines, but they're not necessarily being followed. Hospitals have their own agenda sometimes, but we clearly need to have some good systematic research on dosing protocols as far as I'm concerned.
Thank you.
So I have several.
Yeah, I'm trying to figure that out. Can you, there might be a button. Is there a button?
Is it on when I spoke?
I will repeat the. Why don't you come up, Andre, and answer the question?
I'll answer your question. So one of the questions that I think that needs to be answered is something that Carol had alluded to, and it has to do with the complex presentation of neonatal abstinence syndrome. So we have very good tools for just pure opioids, but that's not always the case that we have women. We have women that we know that have prenatal tobacco exposure. That exacerbates prenatal opioid exposure and the neonatal abstinence syndrome. So can we have tools that can more sensitively and accurately tease apart the neonatal abstinence syndrome from benzodiazepines plus opioids, benzodiazepines alone, tobacco plus opioids, tobacco alone? I think there are a whole host of questions about how we can have sort of the next generation of tools to assess NAS and then how to treat it with the protocols. I think we have a real absence of long-term outcome studies for this patient population, and we need, the data that we have to rely on, with the exception of the mother study, are data from the 1970s, where we had heroin, and a lot of those data were mixed in with methadone plus heroin. And so what do the long-term outcomes look like for the prenatal prescription opioid epidemic that we have now? The other thing, too, is with our medications, our methadone and our buprenorphine, all of the research that we have, with an exception of 10 babies that are going to be in the literature very soon, are focused on Subutex, the mono product of buprenorphine. So what is the safety and efficacy of Suboxone? Because we know out there providers, that's the first medication that providers are using when they're treating with buprenorphine. So what does the safety and efficacy look like with prenatal exposure for the fetus, for the neonate, for the child. And then the combination, what is the relative safety and efficacy with methadone plus benzodiazepines for the fetus and the neonate and for the mother, and the same with buprenorphine. Our randomized controlled trials, because we were asking efficacy questions, had to exclude those women that had the comorbid alcohol and comorbid benzodiazepines. That's not what happens in general practice. We need desperately those answers to those questions.
Thank you, Andre. Go ahead, Dr. Patrick.
I think to echo some of those things, in addition to other drugs, also preterm infants, I've definitely seen even recently, so I'm a neonatologist and I take care of babies in this context too, are overscored often if they're preterm. It's very common to have some breathing problems if you're preterm, and oftentimes these babies get overscored for withdrawal. I also think, understanding what the lay of the land is, outside of institutions like Hopkins or Jefferson or Michigan, where this is a clear issue, what's happening, where are these babies mostly treated? I'll tell you that talking to folks around the country, it seems like it's mostly in smaller NICUs and community hospitals, and that's been highlighted by some recent press and as well. So I think understanding where these babies are being treated and how we standardize things there with limited resources, how the process of care can be streamlined, how we can train people to identify these babies early on and to treat them effectively, as has been said already. And understanding, standardizing dosing is really important. I've certainly seen babies who have been given too much opiates and had respiratory depression from that. So I think those things are what I would consider most important.
Any more questions from the audience? Sure, Jeff. You can come. Is it? Jeff, hold on. Could you come to the mic because the transcriber can't hear the mic? It's not hooked up apparently.
How about this mic? Does that work? I can hear that too. I'm Jeff Laredo from the National Institute on Drug Abuse. You have several important congressional staffers here in the room. You might want or need their help or have recommendations for what the Hill might be able to do, either to help your work or to help federal, state, local officials do what they're trying to do. What would you suggest to them that they can take back to their bosses to at least consider?
My recommendation would be to start with a survey statewide, every state, to find out what hospitals are doing in their own institutions. As we gather that data, then we can begin to figure out what we want what we're going to do about this problem. Can we have a curriculum established for schools? And how can we make it that we can identify these women early in pregnancy just by a simple standard of care? We won't have hospital shoppers. This hospital checks urine tox when this one doesn't. Once we have it all standardized from the onset, then these children growing up, they can recognize and know what they should or shouldn't do. We're replacing values and family morals in the school system. We know that's not an easy task either, but it's a start.
Thank you. Anybody else want to take a stab at? Sure.
I would say, there's two things. One is, a research approach, and another is a policy approach. And I think this has already been highlighted, and it's more, research. Like I'm sure it was pretty costly to do the mother study, and funding more innovative research like they've done, and continue to sort of push along that way, forward thinking and thinking about things that can be done. And from a policy perspective, it's doing the things that are being done now in states like Florida and elsewhere, where they're trying to prevent opiate use and abuse and diversion and things like that before it even becomes a problem, before pregnancy, before it comes to neonates. I think going down those two lines of increasing funding for research and doing the things that we know work already from a policy perspective to make sure that opiate use is used appropriately for things that it needs to be used for, but not used inappropriately.
just to tag on to that, the idea of access to treatment I think is really important, particularly in rural communities, where oftentimes it might be literally one doctor that has to do everything from delivering babies to doing hospice care. And so knowing in your state where are the strengths and the opportunities for increasing access to treatment, because my belief is that treatment should be as easily accessible as McDonald's. And so we want as many treatment programs, and to also have that education at all levels, to educate law enforcement about the illness of drug addiction and the treatments that are available in their community. So there can be statewide resources on a website that are posted that any professional who encounters a drug-using woman can go to and say, you know what, okay, here's where you can go to get help. There should be many doors open for help, and they should not be turned away.
Questions from the audience?
Oh, sure. I feel like we have a tag team going. Either that, or I know I'm going to fall on this cord before the day is over. Obviously, we all think alike, and so we're all expressing the same kinds of thoughts for each of us. But I also want to talk about access to care. We're talking, it's always easy to get excited about access to care for pregnant women. It's not always easy to get the community excited about access to care for opioid-dependent women. These women face tremendous stigma and community pressure. We heard this morning about the importance of family-centered treatment. And if you know what that translates into is residential treatment for women and children so that they can have access to the level of care that they need in order to achieve their recovery, where they can go into treatment by bringing their children so they don't have to make that Sophie's choice of, do I go to treatment and leave my children with somebody that I don't trust? Unfortunately, access to this level of care is extremely restricted for opioid-dependent pregnant women, because you have providers that do not want to provide the appropriate treatment. They'll admit them to treatment as long as they're not receiving medication, as long as they're not receiving buprenorphine or methadone. And so if we're going to talk about expanding access to care for this population and making sure that the women get the treatment that they need, we need to really address the stigma associated with opioid dependence in particular, and with medication-assisted treatment.
I can try it and see is it working? Yeah? My name is Frances Norwood. I'm from the Center for Medicare and Medicaid Services and the Innovation Center. And I'm very interested to hear if some of the panel members can speak to what a successful transition program for families who do present in the hospital with babies who have these problems. What may be the top 3 or 5 elements to a successful program that would transition them back into the community and be able to meet their very particular needs?
Sure, you can try that. Sure. This is the game. Oh, I know.
On our campus, we have the Center for Addiction and Pregnancy. We are happy to be able to take these women from the community. We can get them onto a maintenance drug if that's what is needed. We can get them detoxified, and then we can have them doing counseling, one-on-one if it's necessary, and classroom. Then we can introduce things like how to care for their self first, how to care for their children, maybe other children that they may have, how to recognize their cues that may prevent them from relapsing. We also teach them how to get a job, perhaps get their GED, and then we assist them in getting ready for interviewing for jobs. The problem is this takes a long time. It's not something that could be done in 2 weeks or 4 weeks or 6 weeks. But if we get them there early in pregnancy, we have the rest of that pregnancy to help these women to develop and grow, and then be able to take care of their own children, and hopefully be able to find a better environment in which to live.
Do you want to respond? Go ahead. Do it. Okay. I want to. In terms of your question, you seem to frame it in the context of postpartum, that the mother gets to the hospital and the baby, she delivers the baby, and the problems are identified in the hospital because the infant undergoes NAS. And I think obviously from all of our presentations, you understand that the focus needs to be on identification during pregnancy. Certainly preconceptual is ideal, but we know that's not going to happen. But the point is to identify this early in pregnancy so we can get the women into treatment while they're pregnant, because having prenatal care is of critical importance. So again, it comes back to access, reducing stigma so women don't feel fearful for coming home, to coming into treatment. The issue is that when you have a woman who's abusing drugs, whether it's opioids or any other drugs, she has a big target on her back, and it's called DHS, Child Protective Services. And if she's fearful that if she self-identifies that she's using drugs and she needs she needs help, she runs the risk of losing her children. So you have to find a way to balance that. Obviously, the safety and welfare of the children is of paramount importance, and no one is at all saying that not be followed through on. But we have to find ways of reducing the stigma, of making healthcare providers welcome these women so that they don't feel like they're being treated prejudicially, so that they can come into the system and stay in the system, and then get them into the appropriate programs for them. But until healthcare providers, all of us as a community, whether we're talking about judges, whether they're talking about DHS, whether they're talking about physicians, nurses, all of us that enter the lives of these women, we have to change our attitudes about them, that we know that we can help them, that they can help themselves, that we can provide the services that they need, and that they're not out there making conscious decisions to harm themselves and their babies, but they suffer from a substance use disorder that needs treatment, and we need to be able to provide that for them.
Just to elaborate on what Carol also has already said, the idea of having early relationships with Child Protective Services, or DHS, is really important. So if you're lucky enough to have a woman who is pregnant and in treatment, to have that first CPS, DHS contact be when she's doing well. I also understand it's the reality that many women come in unregistered, without prenatal care, without drug treatment, and then what do you do from there? And the importance of having standardization for CPS procedures, for the criteria for removal of the child, if that's what's going to happen, but also very explicit steps for the woman about what she needs to do to get her child back. I mean, we've seen lots of cases where it's just stay off of drugs. Well, and then she goes to the court to get her baby back, and she doesn't have a car seat, so they don't release that child to her, even though she's been drug abstinent for 2 months and she's done her job. So it's very explicit things so the woman knows exactly what she needs to do if that child is removed, how she can get that baby back.
Okay, just really quickly, I think from a payer perspective, this is a really important question, and I do think it starts kind of earlier on, and it comes at what kind of incentives as a payer can you do to standardize care. I think that's where things start. I think it really does start with interventions in the hospital of trying to get hospitals to adopt a standard unified way of identifying babies and treating them initially. I think that's a starting place. There is definitely a need for care coordination following discharge of newborns. It's on the Institute of Medicine 100 top comparative effectiveness research goals is care coordination post-discharge from a NICU. I think that's ongoing. I think there's just not a lot of evidence about exactly what works. So I think as a payer perspective and things that you could do now, it's a very important question, and I think it starts with that initial hospitalization and using incentives to sort of make sure care is effective at the beginning and start thinking about ways that we can do things effective post-discharge as well.
Hi, I'm Ivan Montoya from NIDA. Thank you for the presentations. I think one of the take-home messages is the importance of comprehensive care of substance abuse in pregnant women and their babies. Part of that comprehensive care is the pharmacological treatment of the women. Right now, both buprenorphine and methadone are Category C medications. They are not approved by the FDA for the treatment of opioid dependence during pregnancy. So they are being, especially methadone is being prescribed off-label, and buprenorphine is being tested, but we have very little information about those key medications for the treatment of substance abuse in pregnant women. Also, there's very little research, very little information about buprenorphine and methadone, but there's more information about methadone and breast milk, but very little information about buprenorphine and breast milk. So with that background, and now with the Affordable Care Act and the importance of getting medications approved by the FDA in order for providers to prescribe them, what would you see will be the agenda for research of medications for substance abuse in pregnant women and neonatal abstinence syndrome?
I think that is what we're going to be talking about moving forward. And I think I just want everyone to be aware that we have people here from the FDA, from their maternal and child health, and also from their opioid group. And our division has as its strategic priority for this year to work on that and to partner, hopefully, with NIDA and some of these other organizations to develop the research agenda. So if there's ideas from our panelists, I'm happy to have them come up and specifically identify, research on medication-assisted treatment issues for pregnant women, if you have some off the top of your head. But that's a very advanced question. So you want to take, okay.
As far as I am a lactation consultant, international board certified, so I was actually the hands-on get the milk sample person for the methadone and breast milk study with Lauren Jansen and Marta Velez. And so in doing that study, we were able, even with new technology, to find out that those levels of medication in the milk were very, very small. Our plan next would be to do the same study, basically using the buprenorphine.
So right now we have 2 medications that can be used in pregnant women, but they're not FDA approved, as Dr. Montoya mentioned. So what are the data that the FDA needs to approve these medications for a use in pregnant women? I think would be a really important research question, to have a collaboration between the FDA and NIDA to set out that research agenda so we know what the questions are that they're looking for to answer. Also, as I had alluded to before, sort of taking now that we have efficacy data on methadone and buprenorphine, the next step is effectiveness data. So let's get these medications out into the real world and ask more real world questions with a real world population. So what are the relative and safety and efficacy outcomes for mother, for fetus, for neonate and child for methadone and buprenorphine in the presence or absence of alcohol and or benzodiazepines and tobacco? With tobacco, we have medication. So we have what does the medication combination of NRT, of tobacco, smoking cessation medications with either methadone or buprenorphine. There's a whole host of questions that really need to be answered along that line, and of course then the breast milk and methadone. And also with the Suboxone, which is the combination product, they have a film strip now. We have absolutely zero data on what that medication formulation looks like with pregnant women in terms of relative safety and efficacy for the mother, for the fetus, or for the neonate.
I'm Dan Radofsky from Senator Schumer's office on Capitol Hill, and my boss has taken an interest, as you guys thankfully pointed out. But I just had a question, sort of, one of the biggest problems I think with the prescription drug epidemic has been that people don't necessarily realize they're addicted to opioids until maybe too late. Is there a point in the pregnancy when it would be ideal to pick up on someone's addiction, or for a doctor, if they're getting prenatal care, to ask a patient, I don't know, what other prescriptions are you on currently, maybe to do some sort of urine toxicology test or something along those lines? Is there a point that it sort of tips the scale whether NAS will be more prevalent in the baby, or do we not know that yet?
Yeah.
So the question was, is there a time at which it would be good for a doctor to have a conversation with the patient, or initiate the conversation with the patient, or test the patient to see if they're on any medications, or to test them if they say that they're not, because we know that a lot of people don't necessarily reveal all of their medication usage initially. Maybe Dr. Patrick could answer this. Or Dr. Cottonbach.
You've raised an important point. Certainly the answer is yes, the doctor should ask. It's not on a continuum. That's a question that should be asked during the first prenatal visit. We tend, and I say this as euphemistically, we don't ask pregnant women the kinds of questions that should be asked in terms of their alcohol and drug use, because it's uncomfortable. We don't necessarily want to know the answer if we don't know what to do about it. Or we ask questions, we frame the question in a way that you're going to get an answer that you want, often, it's an example that's often given is an obstetrician saying, and I don't mean anything negative about obstetricians. This is just given as a hypothetical example because it does occur. You don't use alcohol, do you? Or you don't smoke, do you? Rather than saying, just assuming that you do, how many cigarettes do you smoke a day? How many drinks, what do you drink a day? And asking specific quantifiable questions. That's usually not done. So those kinds of questions should be asked immediately in pregnancy to find out what this woman is doing, what she's using, and then take appropriate referrals from there.
If there's not any additional questions, I will echo that and just give out a little tip. When I worked at the VA, my first supervisor said, if you want to ask a veteran about their substance use, it's always better to give them a hugely large number. So how many six-packs did you have last night? Or how many fifths did you drink? And that would make them comfortable enough to come forward. Now, I just have to point out that in some states, there are definite provider requirements if it appears that there's a problem during pregnancy. So providers will be in the position of needing to report to Child Protective Services in many states. That's something that we're going to talk about more today, and we're going to go ahead and take our break. We're a little bit ahead. Y'all have until 11:25. And we'll stay on task. Thanks.